Good afternoon, ladies and gentlemen. In this talk, I want to analyze the mortality data of children with congenital heart disease. This cartoon is an estimate of the successful story of pediatric heart surgery, starting in 1914 with a mortality of 80% and only 20% survived their severe heart defects. By introducing the congenital heart surgery with BT shunt, further operation, atrial switch operation for turn operation, and atrial switch operation, there is a better prognosis of these children, and 85% survive the severe heart defects in the 2000s. However, the current data in Germany show an increase of mortality in patients with congenital heart defects starting in 2014. We have to realize that the German health system is one of the most expensive health systems worldwide, with a free access of all patients to cardiac surgery and pediatric cardiology. We spent a lot of money to introduce a complete coverage with interventional cardiology in Germany starting in 2000, but unfortunately the prognosis do not improve, and that's not a joke. What about the mortality of congenital heart defects in other countries? And there's every time the same pictures, like shown in this Chinese paper, who show that in infants in patients with heart failure, more than 77% who suffer from heart failure are infants. There are no mortality data in the English abstract, but the mortality correlate with heart failure in this patient group. The data from US show a 14.2% mortality in infants with critical heart defects, and the mortality is very low if the patient survives the first year of life. The German data show more than half of the patients who died from congenital heart disease are infants. There's the same data like shown in a single center study. The US data show no significant improvement of the results between 1999 and 2011. What is the medical treatment of patients with congenital heart disease who develop heart failure? And there's a political decision, and most patients receive diuretics, some patients receive ACE inhibitors, and only a few patients receive beta blocker in this patient group. The US cardiologists treat the hyperplastic left heart syndrome with digoxin. This is not used in Europe no more. Looking to the data worldwide, we know that more than 3 billion of children suffer from congenital heart disease. More than 200,000 died from congenital heart disease, and most of them are infants. Heart failure is the cause of death in around 80,000 infants. By using the single center data, we analyze the evidence for treatment. Most patients who died are infants, but there are only a few trials who prospectively analyze heart failure therapy. That's our own CHF Pro-Infant trial from 2001, the Indian VSD PHF trial from 2013, the US enalapril trial in patients with univentricular hearts from 2010, and the Gießen approach with bisoprolol and hypoplastic left heart syndrome. There are further trials in older patients, like the US cavity trial and the Panorama HF study using sacubitril and valsartan. But unfortunately, these trials don't investigate the results in infants. Who are these infants who die from heart failure? And the best data are the Scandinavian data shown at this slide. With the univentricular heart, there's a high mortality in the first year of life. Around 60% of these children have survived their heart defect. And the highest mortality was shown in infants with hypoplastic left heart syndrome. If I develop beta blocker therapy in Göttingen, we are frustrated about the bad data with a mortality of 40% in univentricular hearts and about around 40% in all children who get aortopulmonary shunts. But today we know that these data are not better than in other analyses like the Sweden analysis or the analysis of the Pediatric Heart Network in US. The Swedish data show an improvement of the mortality in univentricular heart over the last years, and today in univentricular hearts and hypoplastic left heart syndrome, the mortality is even better than in the first years in the late 80s. However, obviously the obstetricians lose the trust in our work, and there is an increase of termination of pregnancy in Scandinavia. For example, in Denmark, from 0.6% to 39% between 1996 and 2013. In Sweden, nearly 60% of patients with univentricular hearts have termination of pregnancy, and although some patients with better operative results, like the truncus arteriosus communis and atrioventricular septal defects, are terminated in pregnancy, most of all probably if some of these patients have genetic anomalies. What is immortality in the other parts of the world, like in India, showing in this slide? There is very good results in patients who had ventricular septal defect repair in India, but if the patients are preterms or have pulmonary hypertension or genetic anomalies like the Down syndrome, the mortality is even higher. Inspired by Milton Packard, I developed a heart failure model in infants with congenital heart defects in at the end of the 2000s, and I could show that, like in adults, we have a neurohumoral model of heart failure in infants with congenital heart disease. The tachypnea is one of the most important clinical symptoms, depends on neurohormonal activation and dysautonomia, and there's a high significant correlation of tachypnea with heart rate, norepinephrine levels, and the mean arterial pressure as the only hemodynamic predictor of heart failure in this group. As a logical consequence of the neurohormonal heart failure model, we perform the first beta blocker trial in infants with congenital heart disease with severe heart failure who are treated with propranolol or digoxin and diuretics. And there is a clear benefit in the clinical heart failure score, who is lowest under propranolol therapy, and a clear benefit for neurohumoral activation with the lowest renin, aldosterone, and norepinephrine levels in the propranolol treated infants. There's a further impact that the hemodynamics is comparable in both groups with a high left to right shunt, normal mean aortic pressure, and pulmonary hypertension. Interestingly, ventricular function is significantly better in propranolol-treated infants who have lower left atrial pressures, and normal ejection fraction is evident in both groups. If we summarize the prospective randomized trials for infants with congenital heart disease and heart failure, there are clear results with the most effective improvement of the ROS score by 60% after propranolol therapy, lower plasma renin rate activities after propranolol, but significantly higher plasma renin activities after diuretic and ACE inhibitors, and lower aldosterone levels in infants who are treated with propranolol. 25 years ago, we realized the impact of propranolol therapy on heart rate variability as an autonomic marker, with significant improvements of the heart rate variability data, SDNN, RMSSD, and high frequency power. In this current abstract from US, we now realize that heart rate variability is one of the most important predictor of postoperative outcome. We can see the higher mortality in infants who have low SDNN and low RMSSD, and the CHF Pro Infant trial is the only trial who improve this important predictors of heart rate variability in a prospective study. However, I was not allowed to further investigate beta blocker therapy in gutting, and I further treat the infants in a little hospital in the rural part of Germany. And in summary, I only treat 43 infants in the last 24 years. All these infants have severe heart failure, and more than the half of the patients have genetic anomalies. We have 4 infants who died despite beta blocker therapy. These are all patients with univentricular hearts and Down syndrome. All other patients survive their severe heart defects and are successfully treated with cardiac surgery. These are all the vagus data from heart rate variability analyzers in these patients, and we see very low RMSSD values and high frequency power values that indicate the high severity of heart failures in our treated patient, and there's an improvement of these data after propranolol therapy, and only 2 patients who not increased their low vagus activity died in the Bad Mergentheim College. I don't have the data from the Göttingen infants who died. Today we know that high frequency power is a very important parameter for risk stratification in critical ill infants. We have our data in infants with critical heart defects compared to the normal data of 24-hour Holter ECG analyzers, there are low data in preterm infants, most of all those who are born before the 32 weeks of age. And we have the data from infants and preterms with necrotizing colitis who have very low heart rate variability and vagus activity and a high risk to die from this disease. Moreover, early life stress like heart failure have an impact on brain development, like shown in preterm. There are those children with the highest norepinephrine levels who have preterm disability or death, and these elevated norepinephrine levels are comparable with our children who have univentricular hearts or Down syndrome. Heart rate variability analysis shows the lowest RMSSD values in those children who are preterm with cerebral palsy and others with bad neurologic outcome have lower vagus activities. Our data show very low vagus activities in children with septal defects, univentricular hearts, or Down syndrome. Thus, current analyses from Zurich now show that the vagus activity have a high impact on the length of stay on the ICU. Those with the lowest half power have the longest stay on ICU, and during long-term follow-up, compared to a healthy control group, those with very low half powers have a bad neurological outcome and a low intelligence. These data now show that children with operated ventricular septal and atrial septal defect have lower heart rates but very low heart rate variabilities during long-term follow-up. This will have an impact on neurological outcome and cardiovascular risk in later life. What about the long-term follow-up of our infants with severe heart failure who are treated with propranolol? Unfortunately, I have only the data from Bad Mergentheim if I don't get my data from Göttingen today. And there are the heart rate variability data up to the 11th year of life from 12 infants who are treated with propranolol in Bad Mergentheim. And we see the normal values as green, red, and gray for high frequency power, low frequency power, and very low frequency power. Showing the vagus parameter high frequency lower, we start with very low values in infancy and have above normal values at the 11th year of life. Nearly the same data are shown for the low frequency power and very low frequency power that are normal on average. This slide shows the vagus parameter RMSSD. In this group of 12 children who are treated for severe heart failure with propranolol in infancy, we see the increase of RMSD short after the introduction of propranolol therapy. There's a decline of the vagus activity after the operation at the end of the first year of life, but during follow-up, there are completely normal RMSSD values in these children. However, what about infants with heart failure due to less severe congenital heart defects like the atrial septal defects who are operated with 4 to 5 years of age? We see that in this group there are very low patients. There are some patients and infants with very low vagus activity, and unfortunately, after operative repair or interventional repair, these children have lower vagus activities in later life. Perhaps if we have a early repair of their defect in infancy, like shown in children with ventricular septal defects or beta-blocker therapy, these children have normal heart rate variability for the rest of their life. However, there are nearly no recommendation for propranolol therapy in infants with congenital heart disease who suffer from severe heart failure. I have not the authority to criticize my group, but I'm very happy that Milton Packer wrote this article about beta blocker therapy in pediatric cardiology. And he explained the reason why pediatric cardiologists don't use beta blockers based on the US Cavidilol trial that is too small, that are the wrong patients and the wrong dose of carvedilol that is used in this trial. Why we do further test propranolol or other beta blocker in this group? That is a financially explanation. If the low cost of beta blockers are the reason that we have no further prospective randomized trials. Let's have a look on this cartoon, and this is the cost to save a life in 10 years in adults with heart failure. And there are only low costs of beta blockers, ACE inhibitors, and spironolactone, but there are very high costs in those who get defibrillators and operative repairs or bypass surgery, and the new drugs have a very high cost to save a life. Maybe that this is a reason that we don't use that cheap drug that is so effective. And this slide describes my role in pediatric cardiology within the last 25 years. The New England Journal of Medicine reports that 9 of 10 doctors agree that 1 of 10 doctors is an idiot. I'm sorry.